As Hunter said, I am with ECU. I have no financial disclosures. I'm not going to be discussing any off-label uses of any medications or products. As far as objectives for this talk, we've got some published objectives, but then we also have an important unpublished objective. In my clinic, I am directly responsible for at least $500,000 of billing every year, but I am indirectly responsible for several $1 million worth of billing, and by billing what I really mean is healthcare cost. As internists, we like to think of ourselves as being the doctor's doctor, and I don't want us to think of ourselves as being gatekeepers. I want us to think of ourselves as being stewards of the entire healthcare system. And when you think about the referrals that we make to specialists, when you think about the testing that we perform on our patients, every single one of those things has consequences, and that leads to downstream cost in the healthcare system. So the unpublished objective today is thinking about how each one of us as a general internist is sort of like the CEO of a multi-million-dollar enterprise making decisions that affect the use of these resources downstream. So why are we talking about this? We don't usually think there's a lot of exciting things to talk about with healthcare maintenance. And the question that comes up is there evidence to support the things that we do? Back in 2007, the Agency for Healthcare Research and Quality commissioned a study to look into this. And they really wanted to know what were the benefits and the harms associated with healthcare maintenance. And so they got this group together and they looked at the best available evidence at the time. They reviewed 10 randomized controlled trials, 2 cohort studies, and 9 cross-sectional studies. That was really all that they could find. And they found that the best available evidence at that time showed that patients do in fact benefit from the periodic health exam through its association with the improved delivery of recommended preventive services, specifically gynecologic exams, pelvic exams, pap smears, fecal occult blood testing, immunizations, cholesterol, and mammography. Now, when you drill down through the data, what you'll see is the overall strength and consistency of the evidence varies quite widely. These studies, these different studies they used, reported on several different clinical outcomes such as disease detection, changes in health habits, smoking, alcohol, that sort of thing, and then also several clinical measures such as cholesterol levels, blood pressure. They also had a few studies that looked at economic outcomes. We think about disability, we think about cost of care, we think about cost of hospitalization, and overall mortality. The authors pointed out that there might have been some reduction in patient worry. That is a bit difficult to quantify. But overall, the authors determined that the periodic health exam did show some benefit, and so that there's continued justification for its use. I should point out the studies were really quite varied in terms of the actual content and then also in terms of what interventions were actually undertaken. It's reasonable to speculate that if you have protected time set aside in the clinic for a physician to talk about these things with a patient, it's much easier to actually do some of these things. And then the other issue that comes up is it's much easier to do things that are done right then and there in the clinic. So in the case of a pelvic exam with a pap smear, that's a very simple thing to do right then and there with the patient. Things that involve a second step are a bit more complicated. So I don't know how many of you have referred a patient for a colonoscopy only to find out the patient never went. That's actually a multiple step process, not so simple, and a little bit more difficult to motivate patients to follow through. Something else that's worth noting is the authors did not consider the actual delivery of preventive measures to be part of the periodic health exam itself. They thought the periodic health exam was really the gathering of the history, performing a physical exam, and discussing what preventive measures should be delivered. So the question that comes up is, why are we doing this? Is preventive medicine taking a hit? Is this cost effective? We've been doing this all this time because we think it's been a good thing to do, but what is the proof? And as clinicians, that is important to us because we like data and we want to know that what we do makes a difference. But we're not the only people that are making decisions here. Payers are extremely interested in finding out if what we do makes a difference. So Blue Cross and Blue Shield is the 800-pound gorilla as far as payers in the state of North Carolina is concerned. Obviously, they care about this a great deal. If they think that preventive health care makes a difference, they're going to make sure that their patients are adequately incentivized to get these things done. If they think that it doesn't make a difference, then what you will find is you're going to have trouble getting reimbursed for your health care. So historically, in the United States, health insurance has been tied to employment. So your people who are employed, they tend to have health insurance. They tend to come in for health exams. People that are not employed might struggle to come in for their health exams. So the question that comes up is, what sort of difference does it make with the Affordable Care Act and with expanding insurance to a population that has not had it? Does insurance equal access? Are there other models? Are there other countries that we can use to help us figure out, as we broaden access to the healthcare system, is it going to make a difference? And the answer is yes, we can look at other countries and we can try to extrapolate from their experiences. Case in point being the national health system in the United Kingdom. So there actually is one Cochrane review of healthcare maintenance exams being done in the British system. And what they found in this Cochrane review is that there are many benefits to a periodic health exam, but there are also many, many harms. And if you just look at the overall list, there appear to be quite a few more harms than benefits. The other thing that's worth pointing out is benefits from a periodic health maintenance exam might take 10, 15, 20 years to really become manifest. These things tend to have a very long lead time. So for example, when you're talking about hypertension, screening for hypertension to try to reduce mortality from heart disease, it might take 15, 20, 30 years before somebody progresses from pre-hypertension to hypertension to actually having their heart attack. And it makes it very, very, very difficult to say that just one particular intervention, screening for blood pressure in an asymptomatic individual, is going to make a very big difference in the long term. Something else that may be a benefit would be looking at a precursor of disease, something that's not necessarily going to lead directly to mortality, or may or may not lead to mortality. So doing a Pap test, looking for cervical dysplasia, you're not looking for the disease itself. Hopefully you see cellular changes from the HPV virus long before the disease becomes manifest. Another benefit that comes up is the patient may actually have signs or symptoms, but they don't understand the significance of them. And so this is a learning opportunity to discuss that with the patient. And finally, having time to talk about lifestyle is extremely important. Most of us, when we're doing a problem-based visit, don't have adequate time built into our schedule to really drill down and talk about the importance of lifestyle modification with our patients. Now, coming to the harms, again, the harms from any test are, generally speaking, almost immediate. So the challenge that comes up is you order a test, there's a complication. You order a test, there's an abnormal result that leads to more testing. Case in point, you send somebody for a mammogram. You have an abnormal mammogram. Depending on how abnormal it is, perhaps what you do is you repeat a mammogram with compression views. The men in the room may say that's not a big deal. The women in the room might beg to differ, particularly if they've had a compression diagnostic mammogram. They may or may not have an ultrasound. They may or may not have a fine needle aspiration. They may or may not have a lumpectomy. And often we pat ourselves on the back at the end of this process saying, thank goodness we had the lumpectomy and everything was benign. But you just subjected a woman to a very invasive workup with no clear benefit to either morbidity or mortality. And certainly there's a lot of angst associated with this entire process. One of the other harms that is not quite as intuitive is the concept of false reassurance. You may go into your physical exam and then find out that, wow, my blood pressure is quite good, my cholesterol is quite good, I'm going to start eating at Bojangles now every single night for dinner. And there are many examples of false reassurance. And so this is, as a pediatrician, one of my greatest fears, and I got this straight from the website for this particular product. And this is a test that allows you to look for the presence of alcohol in breast milk. So you can imagine what it would be like being a pregnant woman or being a woman, a postpartum woman, and it's that time of year again, the holiday party season. Out come the presents, the festivities, and the food. And for some new moms, it may include a few celebratory drinks along the way. But who says that just because you're breastfeeding, you can't get on the fun too? Now, nursing mamas can enjoy the parties and safely nurse their infants with Upspring Baby's Milk Screen. And so I would argue that this is a test that should not be done. And I'm reasonably, I don't think Dr. Christie is here, but hopefully our hospital will never have anything like this. I would argue this is not compatible with our baby-friendly newborn nursery. So just because you can order a test doesn't necessarily mean that you should. So going back to the National Health Service System data, what did their results actually show? You don't have to be an excellent statistician to note that every single one of these studies on the box and whisper plots, the lines cross one. So there's really nothing favoring health checks over control. The studies that were used in this Cochrane trial ranged from 4 to 22 years of follow-up, and you can certainly make an argument that 4 years of follow-up is way too short to actually detect a difference when you're talking about things involving hypertension, dyslipidemia, cervical cancer, that sort of thing. But in general, what they found is that the periodic health exam does not save lives, does not prevent disease, does not reduce hospitalization. So in summary, they concluded that public health initiatives such as the National Health Service health check should be discouraged, and more to the point, any companies that provide generalized screening to asymptomatic individuals are really deviating from the evidence. I'm not going to mention any names, but all of us have probably had patients that have come to us with results from some sort of commercial screening that they had done, perhaps through their church, perhaps through their employer, or perhaps through something they just saw set up in the community. And so anybody who's doing these things is operating outside the evidence. And so this led to a bit of a political firestorm in Great Britain. I know that you can't read everything here on the editorial. Suffice it to say, members of Parliament were very interested in why the National Health Service system was developing this model of health checks if it wasn't going to make a difference in their population. To explain what the system was, what the National Health Service was going to do was have their general practitioner screen everybody in their population aged 40 to 74 for several conditions, including diabetes, chronic kidney disease, lung disease, cardiovascular disease, and stroke risk, regardless of their risk profile. Looking at the population of Great Britain, this would have been about 15 million people, and they were going to do this over a 5-year period, so they were going to screen about 3 million people per year. So the expectation was the GPs would contact every single adult in their panel and invite them in over a period of 5 years. And the most recent data that I have available is from 2012 to 2013. During that year, there were about 3 million people, not quite 3 million, that were invited for health checks, and 1.26 million people actually came in, and really participation was quite low. So that's the British experience, but this is the United States. What's going on here in the United States? Well, the Choosing Wisely campaign is something that you may have heard of, and many different specialty societies have been contributing to the Choosing Wisely campaign. The whole point behind this, again, is we want to be good stewards of our health system resources. So the Society of General Internal Medicine has weighed in with its list of things that we should not be doing. And what I want to do is zoom in on element number 2, which states don't perform routine general health checks for asymptomatic adults. So according to my clock, it's right now 8:17, so if I stopped right here, this would be the shortest grand rounds I think we've ever had. Unfortunately, I'm not going to stop here, so you have to keep listening a little bit longer. The take-home lesson here is not that You should not be doing screening in asymptomatic individuals. The issue is you need to be smart about how you do it, you need to be selective in how you do it, and you need to be doing the right test in the right patient at the right time. And if you actually read the text, that's exactly what it says, that we should be following evidence-based preventive strategies and not necessarily screening every single individual for every single thing, doing the exact same measures without any thought. So let's talk a bit more about how you prioritize things, because this really is the crux of the matter. How do you decide what to do in any one particular individual? So when you think about screening, the concept here is you're trying to detect a condition in a patient when the patient is asymptomatic, preferably, or perhaps having minimal symptoms. It should be a condition where if you intervene, it actually makes a difference, hopefully prevents mortality, reduces mortality, delays mortality. Your screening measures should be reasonably cost effective, and there should be minimal harm to the patient. Now, above and beyond that, there are two different general strategies you can use when you're doing screening. You could screen every single asymptomatic individual, and that would be a mass screening or a universal screening. Or what you could do is you could try to select a specific population within which to screen. And depending on the condition, it's appropriate to do either strategy. Probably the best example of mass screening would be that of the newborn metabolic screen that we do on babies. And it's actually a fascinating example of universal screening, even in private health systems that don't have universal access. Really, the first metabolic screen that was done widely in babies is PKU. And so a lot of families really understand the concept of the PKU test. Phenylketonuria causes severe cognitive impairment, severe. And if you intervene very early by putting that child on a restricted diet, you can completely prevent the cognitive impairment. It's a relatively rare disorder. You see it in about 1 in 15,000 people. So what that means is there are about 275 infants born with PKU every year. It's only 275 in the entire country. But what we do is we screen every single baby that's born in the United States for this condition. This intervention really started about 50 years ago. That's when the first state laws were passed, actually mandating universal screening. By 1965, 32 states here in the United States required the testing. By the mid-1970s, it was ubiquitous throughout all industrialized nations. Regardless of whether they had universal health care, everybody was doing it. And so that's a really good example of how universal screening has made a difference. Now, when you look at targeted screening, the issue here is you're really trying to select a population where your pretest probability of them having the condition is going to be higher. And so another good example here would be use of a PPD test, screening for tuberculosis. It used to be that we did those on everybody when they came in. And lots and lots and lots of health forms would require a PPD, really for no reason. They would just require a PPD. And now what we do is instead of automatically placing a PPD on our patients, what we'll do is we'll ask them questions. Have you been in a nursing home? Have you been in a psychiatric facility? Have you traveled overseas? And ask them other questions. And the whole point behind that is you're trying to select for a particular population. And if you're taking care of a high-risk population, then it is appropriate to screen everybody in that population with a PPD. So, for example, if you've ever taken care of an inmate when they come from the correctional institution with their chart, they have an extremely thick chart that has all kinds of data, and every single time they re-enter the prison system, they're going to have a PPD placed. And so that would be an example of targeted screening. So the point that I want to make here is there's an extremely limited role for mass screening in asymptomatic individuals. When you look at the U.S. Preventive Services Task Force guidelines, they recommend a total of 34 different screening measures to be done in adults, but very few of those are done in every single adult. One of the things that's done in every single adult is measuring for blood pressure. That's probably one of the best examples of a screening test, and we don't usually think of it as a test. We think of it as just being one of the vital signs. But really, that's one of the best measures for screening for heart disease. You've got a relatively simple test. It's a low-cost test. It's a non-invasive test. And you have a very long time to intervene and prevent heart disease by controlling blood pressure. When you look at JNC7 recommended that all asymptomatic individuals have their blood pressure checked every 2 years. If you're a higher risk individual, they would suggest that you have your blood pressure checked more often. That was the whole concept behind pre-hypertension, which was something that was created in JNC7, where patients that had pre-hypertension, they recommended that they have their blood pressure checked at least every year. And that's really the only reason why that mattered. Diabetes. The reason why we screen for diabetes really is to help us predict who is going to have a higher risk of heart disease. And we know that people with diabetes are at significantly increased risk for heart disease. And so people with high blood pressure, sustained over 135, over 80, as defined by the U.S. Preventive Services Task Force, should be screened for diabetes for that reason. Alcohol use and misuse. The issue here is trying to figure out, is the patient at risk for other complications later on? The way that the U.S. Preventive Services Task Force defines misuse of alcohol in women is 7 drinks per week or 3 at one time. In men, it would be 14 drinks per week or 4 at one time. HIV, we should be screening for HIV infection in everybody from adolescence all the way through age 65. Beyond age 65, if the patient is at increased risk based upon history, you should screen. Younger than adolescents, if they're at increased risk, they should screen. CDC and the U.S. Preventive Services Task Force have worked very hard to change the consent rules involving HIV screening. It should be universal. You should not have to sign any other consent forms. The whole point behind that is there are a lot of people walking around with HIV who do not know that they have it. And so again, that's something that's very appropriate for mass screening. Depression, the issue that comes up with depression is you should screen for depression, but if you don't have a good care system in place to actually manage depression, it makes things complicated. So you need to know what your local resources are as far as therapists, counselors, people to help you manage depression. I'm not going to talk a lot about JNC8. You'll notice when I was talking about hypertension, I was focused on JNC7. JNC8 was a lot more specific in the management of hypertension as opposed to being a comprehensive guideline set to cover all aspects of hypertension. And I know that you can't read everything that's up here, but the point that I wanted to make is when you look at these different columns on the algorithm, what they're doing is they're defining different age groups. And so, for example, we're changing our blood pressure target for patients above age 60. That's been very controversial, but in the population over age 60, we should be initiating treatment to try to get pressure below 150 millimeters systolic, 90 diastolic. I'm not going to spend a lot more time on that. We can have cardiology topics that talk on that. Let's go into more targeted aspects of screening. The reason why we ask about smoking is smoking increases the risk for other conditions. One of the things that smoking increases the risk of is lung cancer. I'm not going to talk more about that because Dr. Bowling has covered that in excruciating detail during previous grand rounds. As far as AAA screening, the rationale here is in men who are age 65 to 75, they actually have a pretty decent operative risk when they have an aneurysm, if you can find it at an early enough time. Men over age 75 have a much higher operative risk. And so the reason why we don't screen men over age 75 is they're more likely to die when they have their aneurysm repair. And so the risk exceeds the benefit. The reason why we're not screening women, all women who smoke, is again, their operative risk is different. And so the issue that comes up with screening is you always have to balance the risk with the benefit. If Women tend to develop their aneurysms later in life, and they tend to have a higher risk of mortality in the operating room. There really is no point in screening them because it is not going to make a difference in their overall mortality. That is why we do not screen women with ultrasounds looking for an abdominal aortic aneurysm. There are other tests that we do based upon the age of the patient. Now, for the med-peds people in the room, one of the things I'll point out is Bright Futures recommends that we start screening very young adolescents for hyperlipidemia. The issue there is our population is changing faster than the evidence that we have in the literature. And so it's really difficult to say how much evidence we have supporting that particular guideline. And the other issue that comes up is if you do find hyperlipidemia in an adolescent, usually we recommend a stage 1 AHA diet. We're not usually talking about starting them on statin therapy or other lipid-lowering therapy. In contrast, when you're dealing with adults, when you find hyperlipidemia, you always talk about lifestyle modifications, but now with the most recent AHA guidelines, we're going to go ahead and start putting patients in different categories: no statin, low potency, medium potency, high potency statin. And again, I'm not going to talk about that in great detail. That's beyond the scope of this talk. That's again an entire grand rounds all to itself. As far as hepatitis C infection is concerned, the issue here is the hepatitis C virus was not identified and routinely tested for in the blood supply prior to 1992. So anybody who might have gotten a blood transfusion prior to 1992 or might have engaged in behaviors exposing them to blood or blood products prior to that time could be at increased risk for hepatitis C. Again, it has a very long time, latency time until symptoms, and the more important thing is now we actually have good medications that can make a difference in hepatitis C. And so again, there is benefit to identifying and treating. And so that's something that's very exciting. It's very different from just 10, 15 years ago. Now, as far as colorectal cancer screening is concerned, I want to use this topic to point out that guidelines are just that, they're guidelines. And I don't want you to think that guidelines means standard of care. And so you'll see here that I've got the U.S. Preventive Services Task Force guidelines. I have the American Cancer Society guidelines. The whole concept of guidelines comes from mountain climbing. If you are not an experienced mountain climber, let's say you're a novice mountain climber, you don't know where you're going, you don't know what you're doing. You get a guide to help you. The guide goes up the mountain first, picks the best approach, perhaps the easiest approach, or perhaps the approach that he or she thinks is best for your skill level, and then goes ahead and secures the lines, the wires, by hammering them into the rock, and then you follow that path up the mountain. It is a path for you to follow, hopefully the best path forward, but it's not the only path forward. Guidelines are not standards of care. They're things that are there to help guide decision making. You are allowed to deviate from them, but you need to have a pretty compelling reason to do so. The other issue that comes up is different societies have different guidelines. You do get to pick and choose which guidelines you're following, but you need to understand why you are following the guidelines that you are following, and you have to be able to justify that decision to yourself, to your patients, to your partners, and to anybody else that's interested in your medical records. Looking at these particular guidelines, there are some similarities. People do generally agree that we should start colon cancer screening in asymptomatic individuals at age 50. And again, I want to stress asymptomatic individuals. I'm not talking about surveillance colonoscopies here. So for example, if you know that somebody has a familial condition that leads to increased risk of gastrointestinal disease, you're going to be doing surveillance studies. That's not what I'm talking about here. These are asymptomatic individuals who are not at increased risk, do not have a familial predisposition. U.S. Preventive Services Task Force notes that you can do a colonoscopy, you can do a high-sensitivity fecal occult blood test, you can do sigmoidoscopy. They do not recommend the CT colonography, and there are a couple different reasons for that. Issue number one is every time you do a colonography study, you're subjecting that patient to a pretty significant radiation burden. And then the other issue is with CT colonography, there's a high risk of detecting incidental findings outside the colon, and then that's going to lead to other testing. Let's say you find an adrenal adenoma. What are you going to do with that? And so again, the whole point behind this talk is to point out that we need to be good stewards of our resources, not order tests that lead to lots of additional downstream testing. Something else that's worth noting is the Preventive Services Task Force says that we should not routinely screen adults aged 76 to 85. Now, we know that older patients are at increased risk for developing polyps. The older you are, the greater the likelihood that you develop them. The issue that comes up here is the older you are, the greater the risk of having a complication during the procedure. And if there's a polyp that cannot be removed, or multiple polyps, or a much larger cancerous lesion, that patient may or may not be a good operative candidate. So again, you have to look at the risk to benefit ratio. And then Preventive Services Task Force also states that beyond 85, you really shouldn't be screening at all. The estimate that's often used is the 10-year lifespan estimate. If you think your patient's not going to live another 10 years, you probably should not be screening them. Now, when you look at the American Cancer Society guidelines, they do not have an upper age cutoff limit at all. And so they would say that you continue screening, you continue screening, you continue screening, but they do make a note in their guidelines that you should be thinking about the life expectancy of your patient. Now, there are also several different screening measures that are specific to women. I'm going to have a couple slides devoted to breast cancer screening, so I'm going to jump over that. Likewise, cervical cancer screening. Chlamydia and gonorrhea. They're worth mentioning, chlamydia being the most common reportable disease in the United States, and gonorrhea being the second most common. And I don't know how many people are routinely screening for that during their adult health maintenance exams. In women under age 25, we should be screening annually. In women over age 25, if they are identified as being at risk, we should also be screening those women annually. And the way that you screen is with the nucleic acid amplification test. You do not necessarily have to do a pelvic exam and get a cervical culture. Using something such as a vaginal swab or even a urine collected DNA amplification test is considered an adequate screen. Women at increased risk are women who have multiple sexual partners, especially if they are inconsistent with the use of barrier forms of contraception, women who are engaged in sex work, women who present to your clinic with sexually transmitted infections. Any and all those women should be screened. You might ask yourself, why are we just screening women? Why are we not screening men? Don't women get these infections from men? And the answer is men are more likely to have a symptomatic infection. When they have gonorrhea, they're more likely to have symptoms. They're more likely to hopefully present to your clinic to be treated. And so it doesn't make sense to screen asymptomatic individuals, because asymptomatic individuals probably do not have the disease. Symptomatic individuals are going to have the disease. The exception to that is probably the subpopulation of men who have sex with men. They probably should be screened. Osteoporosis, the issue that comes up here is we should be using the World Health Organization FRAX calculator on all of our patients if the woman's risk of decreased bone mineral density is at least as high as that of a 65-year-old woman with no additional risk factors. She should be screened. You can easily get to the Health Organization FRAX tool through any of the internet browsers. There are a number of other screening tests that are more specific to pregnant women, and our gynecology colleagues are very good at looking at these things, but these are things that also we should be thinking about as general internists. Often I think what happens is as soon as we discover our female patient's pregnant, we decide to ignore her for the next several months. Often we are good enough to put her on prenatal vitamins and send her to gynecology and to make her somebody else's problem for a while. The issue is if we're doing that, we are doing her a bit of a disservice. I'm not saying that you should be automatically testing all your pregnant women with urine cultures. Gynecology will do that for you, but I want you to be aware of the things that they are doing for the women that are under your care. Breast cancer screening. I'm going to talk real fast through this because I don't want to really go too deeply into an extremely controversial subject. What I do want to point out is, again, there are differences of opinion regarding what you should be doing and when you should be doing it. The most important thing is you have to understand why you're doing what you're doing with your patient population. What everybody agrees on is age 50 and up, we should be doing mammograms. We differ on how often we should be doing them. We differ on how long we should be doing them. We differ on what other sorts of screening modalities should we be doing in addition to mammograms. And we also differ on how early we should be starting mammograms. I'm going to come back to that point later. One of the key issues that comes up here is one of overdiagnosis, overtreatment, and trying to reduce the burden of unnecessary downstream testing. And again, as I mentioned before, anytime you have an abnormal study, all the harms immediately accrue. Any benefit may take time to accrue. And so recently there has been an effort to try to expand the time between mammograms from 1 year to 2 years. The rationale behind that is most of the benefit of getting a mammogram every other year is almost as good as getting a mammogram every year, but by definition you've reduced the harms almost by half. When you look at the Affordable Care Act mandates that all preventive services that have a grade A or grade B recommendation from the U.S. Preventive Services Task Force should be paid for by insurers with no first dollar requirement by the patient. What that means is no copay. And so people can get screening measures with a grade A or a grade B recommendation from the task force with no copay. The one exception to that rule is mammograms. And what's interesting about mammograms is it was specifically written into the Affordable Care Act that women can get mammograms every single year without a copay. And the reason why that exception was written in is the Preventive Services Task Force is in the process of revising the 2009 guideline. And during the public comment period, when it was revealed that they were thinking about changing their guideline to mammograms every other year, there were a lot of advocacy groups that started to lobby their members of Congress. And so again, this is a fascinating example of how insurers are making decisions, other people are making decisions, and I would argue that as physicians we need to make sure that we have a voice in this process. If you think that it's in your best interest to let other people make these decisions for you, I would argue otherwise. Something else that's worth noting is U.S. Preventive Services Task Force doesn't see good evidence that clinical breast exams should be done in addition to mammograms. The issue that comes up is there are lots of false positives with a clinical breast exam, and we think that we find a lump and then we subject a woman to an ultrasound with a fine needle aspiration. Again, that leads to further downstream testing. Likewise, they don't see clinical evidence with self-breast exams. Notice the American Cancer Society is a strong proponent for both self-breast exam and a clinical breast exam. Now, something else that dovetails with breast cancer is the risk of breast cancer. Every single one of us that's been practicing a while has a horror story of a woman who developed invasive breast cancer in her 30s, and then there we are taking care of a patient, has small kids at home. She's had a horrible breast cancer, spreads to both breasts, has mastectomy, double mastectomy, has chemotherapy, has radiation therapy, does poorly. Every single one of us has taken care of that patient or knows about that patient. And those are the patients that really we worry about when we think about these mammogram guidelines. So the question that comes up is there a way you can identify those patients? You may not be able to identify all of them, but you can identify a lot of them. And this is where testing for BRCA1 and BRCA2 come into play. In the general population, 12.3% of women are going to develop breast cancer in their lifetime, and 2.74% are going to die from the disease. If the woman is BRCA1 or BRCA2 positive, her lifetime risk of breast cancer increases from 12.3% to 45%, maybe even as high as 65%. And so that really identifies a more targeted subpopulation. When you look at ovarian cancer, we really don't have a good screening test for ovarian cancer. The challenge that comes up is you may or may not be able to detect a palpable mass. By definition, the pelvis is designed such, well, I don't want to use the word design, but we'll say the pelvis is able to accommodate a growth the size of a term infant. And so you may or may not be able to appreciate a mass. we really don't have a good way of screening for ovarian cancer. And the challenge that comes up here is 1.4% of women will develop ovarian cancer. 1% will die of their ovarian cancer during their lifetime. If you're BRCA1 positive, the risk of ovarian cancer increases to 39%. If you're BRCA2 positive, risk of ovarian cancer increases to 10 to 17% by age 70. So you're going to test all women for BRCA1 and BRCA2? The answer is no. You're going to get a very detailed family history. Remember, your family history is your best genetic test. And so these are the things that you're looking for on your family history. If they're positive, that's when you would refer the patient for genetic counseling and suggest that she undergo BRCA1 and BRCA testing. Switching gears a bit to cervical cancer screening, one of the challenges that comes up here is trying to figure out what to do with HPV testing. What we know is that women who are under age 30 are more likely to have HPV, but they're also more likely to have the findings associated with HPV resolve on their own. And so if you're less than age 30, there really is no evidence to support HPV testing. Over age 30, the advantage to doing HPV testing in addition to a Pap test is that you can lengthen the period of time between tests. I have a lot of women that come to my office that are programmed to get a Pap test every single year, and that is not what is recommended. And again, I want to point out these are asymptomatic individuals. If you have an abnormal Pap, by definition, you're now following a surveillance protocol that's different. If you are asymptomatic, meaning you have normal studies, and you're over age 21, what we recommend is you have a Pap test every 3 years. Not every year, every 3 years. More testing does not necessarily make a difference. That will be over-testing, inefficient use of our resources. Starting at age 30, if you were to do HPV testing, what we call co-testing at the same time as your Pap test, you could lengthen the period of time of testing to every 5 years. Not every year, not every 3 years, every 5 years. And we would do that up to age 65. Now, the question that comes up is, when do we stop doing Pap tests? Pap test is looking for cervical dysplasia, which is a precursor to cervical cancer. Once you get through menopause, the likelihood of you developing cervical cancer drops precipitously. If you've had a hysterectomy and your cervix is gone, you are probably not going to get cervical cancer. Again, all of us have patients that will come into our office, they've had a hysterectomy and they want to get their Pap test. And then it's an interesting conversation with them trying to figure out what it is we're going to do a Pap test on. Now, having said that, there are women that have hysterectomies for malignant reasons, and if that's the case, then testing is warranted. Again, that's a surveillance test. That's not a screening test. Here we're talking about asymptomatic individuals. Interestingly enough, the U.S. Preventive Services Task Force says age 65, that's when you stop. American Cancer Society has slightly different rules. What they say is once you hit 65, assuming that you have been adequately screened, and that's a very important point to make, if the woman has not had appropriate access to care, you don't automatically stop at 65 if she's never been screened before. It could be that she has cervical dysplasia. It could be she has cervical cancer, doesn't know because nobody ever looked, in which case you would screen that woman. But assuming that she has had regular testing, good access to care, normal results, you would stop testing. If she had a cervical precancerous lesion, you would continue testing for a total of 20 years beyond the diagnosis. At that point, you could stop. Now, one of the other exciting things that we're doing now in pediatrics is we're giving an HPV vaccine. And so it's going to be fascinating to see what the epidemiology looks like 40 years from now. We're hoping that the Gardasil vaccine and the Cervarix vaccine are going to make significant differences in the prevalence of HPV. But at this time, you continue screening regardless of HPV immunization status. Now, there are a number of tests that are specifically argued against by the U.S. Preventive Services Task Force, things that patients commonly have done. Again, there are lots of companies that do screening on asymptomatic individuals with carotid ultrasounds, and your patient will come to you with a report in their hand saying, I had this test on the blood vessel in my neck, and I had such and such finding. Now what do I do about it? And the issue that comes up is most patients who have strokes due to carotid stenosis are going to have symptoms from their carotid stenosis before they have the stroke. The other issue that comes up is there is significant morbidity and mortality associated with carotid endarterectomy and carotid stenting. And so in an asymptomatic individual, if you do a carotid ultrasound and you find a stenosis, there is a pretty significant risk from that procedure. And so what the U.S. Preventive Services Task Force is saying is that, again, the risk-benefit ratio really is not acceptable here. COPD is another interesting example in that it is extremely common. There are lots of patients who smoke. There are lots of patients in Eastern North Carolina who smoke. We do have medicines to control COPD. Doesn't it make sense to do spirometry on everybody who smokes looking for COPD? And the answer is probably not. And the reason for that is when a patient has COPD, by definition, it's going to be a progressive, irreversible condition. And when they get an exacerbation of COPD, by definition, they're going to come to your office with symptoms. And so if you detect their COPD earlier, really all you're going to do is just delay the onset of their first exacerbation of COPD. You're not really going to change the underlying condition. If the patient is symptomatic, that's when you begin treatment. If the patient's not having symptoms, they're not going to be as motivated to start an inhaler regimen on a condition that really they're not going to be able to change. Prostate cancer is another interesting example. And the lifetime risk of prostate cancer is about 15 to 16% in men, but the lifetime risk of dying from your prostate cancer is only about 2.8%, and about 70% of those deaths occur after age 75 years. There have been lots and lots of studies. We're familiar with the European study and then also the PLCO, prostate lung cancer, colorectal cancer, ovarian cancer studies. And they did not show a benefit of PSAs. The problem with those studies is, especially the European study, had a high Scandinavian population, not a lot of black or African American population, and we know that the mortality in the United States in the African American population for prostate cancer is a lot higher than that of other groups. And that's been one of the main arguments against that study. That's why the VA health system started the PIVOT study a number of years ago. And the PIVOT study included roughly 30% African American population. And their data is actually very similar to that of the PLCO trial and the ERSPC trial. And so, again, the whole point of prostate cancer screening is you should not be ordering PSAs without having a very long and detailed shared decision-making conversation with your patient. I'm going to switch gears. I've got just a few minutes left, and we're going to go from talking about screening tests to other things that involve health promotion. And I'll take just a few moments to talk about immunizations. And again, the MedPeds people are very used to talking about immunizations because we always think about kids and their shots, but there are lots of immunizations that we should be doing in adults. We're going to start with the easy ones first. Influenza, we do that all patients every year. That's easy. What's not so easy is knowing that there are multiple versions of the influenza vaccine. You have the trivalent vaccine. You have trivalent inactivated. That's what gets injected. You have trivalent nasal. That's a live attenuated virus. You have a quadrivalent vaccine that has 4 strains, not just one influenza type B, but actually 2 type B, 2 type A. You also have the high-dose influenza vaccine. How do you decide who gets what? Well, adults over age 65 can receive the high-dose influenza vaccine. The data showing a benefit is somewhat mixed on that, but that is who that vaccine is approved for. Patients aged 2 to 49 years of age that don't have any other high-risk medical conditions such as asthma can receive the live attenuated vaccine up the nose. Everybody else gets an activated influenza vaccine. Tetanus, TD and TDAP. It's been fascinating watching the changes with TDAP over the last few years. The whole point behind the AP is we worry about pertussis, particularly in unimmunized infants, high risk of mortality. And so the whole point behind immunizing adults is to try to protect unimmunized infants. The reason why we don't do mass immunization of every single adult with TDAP on a regular basis is immunity wanes after about a year. You cannot maintain your immunity to pertussis. And so the way the guidelines are written right now is every woman in her pregnancy, preferably during the 27 to 36 week period, should receive a TDAP vaccine with each pregnancy, regardless of how long it's been since the prior TDAP. At this point, we're not routinely recommending that her partners get a tetanus with pertussis immunization. That is something that you can consider doing in your office. So, for example, the woman's husband, the woman's parents, other people that will be involved in the care of that newborn child, you could make a cocooning argument and give those people TDAP, but right now that's not specifically recommended by the ACIP. Varicella and zoster, essentially two different versions of the same thing. The zoster vaccine has a 14 times higher concentration of the varicella virus than the standard varicella vaccine. Zoster vaccine should be given to adults once at age 60, regardless of whether they have had an episode of shingles. You give it. You give it at age 60. Varicella vaccine should be given to people that do not have a documented history of immunity. What that means is that you have documented that they've gotten 2 doses of varicella vaccine at least 4 weeks apart, or they were born in the United States prior to 1980 when chickenpox was still relatively endemic. So those of you that were born 1979 and before, you can say just because you were born at that time, you're probably immune to chickenpox. People that have had varicella diagnosed by a healthcare provider, the problem with that particular definition is we don't see chickenpox nearly as often as we used to in the pediatrics clinic. It'll be interesting to see if that disappears over the next few years. And then laboratory evidence of immunity. You can always draw titers. HPV vaccine. HPV vaccine was studied in adults up to but not beyond age 26, so we can give it in adults up to but not beyond age 26. I want to point out just a couple changes in the immunization schedule. This is what it looks like. The pediatricians in the room are pretty familiar with how you read it. The yellow bars, when there's a long bar, that means that all patients who fall within that age range can receive that immunization anytime. So for example, influenza, everybody gets it every year regardless. And then the tetanus, everybody gets a tetanus every 10 years regardless. If you've never had a TDAP, then you get a TDAP at least once. And again, if you're pregnant, you get a TDAP with each pregnancy. Purple bars mean that you have a higher risk population and you need to be thinking about doing those immunizations. Red bars, which will come up on the next slide, mean that that immunization is contraindicated in that particular population. I want to point out that the positioning matters. You will notice that there are 2 different pneumococcal vaccines. The PCV13 is on top of the PPSV23. What that means is if your patient is eligible for the PCV13, you should give that one first. And the fact that it is on top is meant to be a visual reminder that if your patient deserves that vaccine, you give that vaccine first. This is the chart that shows high-risk indications. And again, red means contraindicated. And the way to remember this, live virus vaccines are going to be contraindicated in patients that have issues with their immune system. Notice that HIV in and of itself is not a contraindication. It depends on what your CD4 count is. I'm going to spend just a moment more talking about pneumococcal immunization. So again, the PCV13 protein conjugate vaccine, more likely to get a robust immune response, but it only has 13 serotypes. So the good news is you're more likely to get a good antibody response, but you're only going to be protected against 13 serotypes of pneumococcus. If your patient is immunocompromised, this is what you're giving. If your patient has chronic renal failure, nephrotic syndrome, they don't have a spleen, they have a cochlear implant, or they have something else that's violating the integrity of their central nervous system, you're going to give them a PCV13. And then what you do is you wait at least 8 weeks and then give a PPSV23. Now, the PPSV23 is what we more commonly refer to as Pneumovax, and there are a lot more indications for Pneumovax. Any adult over age 65. Any adult younger than 65 who has chronic lung disease, diabetes, liver disease, alcoholism, anybody who smokes cigarettes, anybody who's in the nursing home. Lots and lots and lots of patients deserve a PPSV 23. The other thing that's worth noting is when do you give a second dose? Often there's a lot of confusion about that. If you get your first dose before age 65 and you have a qualifying health condition such as chronic renal failure, nephrotic syndrome, you don't have a spleen either because you have sickle cell disease and you've autosplenectomied yourself or your spleen was removed by a surgeon, you would give another pneumococcal vaccine. If you receive your first dose before age 65, you get another dose when you're 65 or older if it's been at least 5 years since the last one. If you don't get a dose until after you're 65, you're done. You don't need to repeat it every 5 years indefinitely. The Hib vaccine, Haemophilus influenza. If you don't have a spleen, you deserve a Haemophilus influenza vaccine. If you know that your patient is going to have his or her spleen removed, it's advantageous to give them the Haemophilus influenza vaccine at least 2 weeks before the splenectomy. Obviously, in the case of a trauma or something leading to a emergent removal of the spleen, you don't get that choice. Then finally, some other high-risk individuals, meningococcal. We give that prior to entry into college, prior to entry into military service. The issue that comes up here is proximity in the adolescent young adult population. Mortality is quite high. Now, what we're doing is we're giving the first dose to extremely young adolescents, and if it's been 5 years since that first dose, when they go into college, they get a booster. Hepatitis A, 2 doses at least 6 months apart. The thing about hepatitis A is it's usually a self-resolving illness, but you can see cases of fulminant liver failure requiring liver transplant. Failing that, patient could die. And again, it's very simple to give the immunization. As far as other high-risk individuals, men who have sex with men, patients who use illicit drugs, researchers who work with primates, patients with chronic liver disease, people who are planning on traveling to an endemic area. Hepatitis B, I think we're very familiar with that because all of us as healthcare workers have to be immunized against hepatitis B. As far as other high-risk individuals, people who are current or recent injection drug users, people with diabetes, people with end-stage renal disease, people with dialysis, people with chronic liver disease. So thank you for bearing with me to the end. Best 4 words in the Grand Rounds talk are so in summary. Here we are. Everybody sits up a little bit more straight. The role for mass screening is limited. We really should not be doing the exact same head-to-toe periodic health exam in every single individual, ordering every single test without a fair amount of forethought. There are a number of things that we should be doing in all our patients. We should be measuring blood pressure. That's a good example, and we should be doing that in every patient, every visit. But as far as the other tests that we do, we really need to think a little bit longer about why we do what we do and make sure that the things that we order make a difference. This is important for our patients because it reduces the stress, the angst associated with unnecessary testing. This is also important financially. It's important financially to the patient, and it's also important financially to the healthcare system. So what we should be doing is following specific evidence-based preventive strategies. We should be talking to our patients to identify who's in a high-risk population. The immunizations remain important. They can be thought of as victims of their own success. It's been a while since a lot of us have seen a case of tetany or seen a case of varicella. And so often your patients will not understand the importance of these things. And so it's extremely important that you understand the benefit of the immunization, because what we do know is that the most important resource to the patient is their physician. And so really, you should be the best advocate for your patient. You should be able to counsel them appropriately about the vaccines. And then again, the last comment that I'll make again is this is important for your patients, this is important for your practice, but then most importantly, this is important for the entire healthcare system. And I would argue that as general internists, we are the most important doctors in the healthcare system because we're the ones who dictate a lot of the downstream cost from testing and referrals. So with that, I will stop. I've got just a moment for any questions, and if people need to leave, I'll be available for questions down front. Thank you for your time. Yes, sir.
Great talk, Lacey. Are there any administrative data, or you can address your own experience? And if you do your own experience, that would do your private practice experience, of what percentage of patients, not percentage of visits, but percentage of patients that's in a practice are asymptomatic adults?
That's an excellent question, and the way that I'll answer it is when you look at most private practices, a typical general internist is going to have a panel of around 2,000, maybe 2,500 patients. When you look at a family medicine physician, it's not unusual for a family medicine physician to have a panel of 3,000 or more patients. And you might ask yourself, why is there the difference? And the reason is family medicine physicians are going to be taking care of more children. And the other thing is a lot of patients will self-select to see an internist if they have more health conditions. And I don't want anybody to think I'm denigrating our family medicine colleagues in any way. We're not better, we're different. And the point that I want to make is if you had a panel of 3,000 completely healthy patients, you would probably not survive economically because your patients are not going to be coming in for services. And so when you think about the fact that an internist is probably going to be taking care of a sicker population, by definition, you're going to have to narrow your panel size. Getting back to the original question, it can be a real challenge. One of the jokes that I have with my patients in my office when I see a man in his 30s is the question is there anything that's actually wrong with you, or are you here because your wife or your girlfriend told you to come in? You know, often that's what happens. Women tend to be the bosses in their households of healthcare, and specifically preventive healthcare. Really, the issue that comes up is we probably don't need to be seeing men that often, assuming they're not smoking, assuming they're not drinking alcohol to excess, assuming that they don't have hypertension or hyperlipidemia. That doesn't mean that we shouldn't see them at all. It just means that we need to take the time to talk to them about their risk factors when they come in. And as a case in point, yesterday I had a fella in my clinic who was 34, and we were talking about the pooled risk cohort equations for the American Heart Association don't really apply to him because his total cholesterol was only 115, which is below the level that the risk equations were standardized for. They were standardized for 130 and higher. And then he's also too young. You really need to be 40 or up for those equations to really apply to you. And so it's interesting, depending on the nature of your panel. If you had a fair number of young adults, you would have to have a much larger panel in order to survive, because you're just not going to see those folks in your clinic until they get sick. I think we are out of time, but I will be available for any other questions down front. Thank you.
Thank you.
Thank you.
This is very relevant for boards as well. I would say I wanted to add, and it's also important for boards. The question about prostate cancer.
Yes.
So, this is not just non screening.
Wait, I'm sorry. You the first one.
Prostate cancer.
Yes.
Yes, no recommendation for screening. Well, you should not do screening.
You should not do it without talking about it. So the issue is you should not be automatically doing it with asymptomatic individuals. Now, there's a lot of politics associated with this. So